all hear each other. First of all, welcome to the ECMO Specialist meeting hosted by ECMO Resource. We have, or I can see, lots of international guests around, so it's really nice to see such a global community of ECMO specialists. Just a quick, some information on what ECMO Resource is. It's an organisation that was founded by Nicole Regan in 2018 with the goal of connecting global ECMO communities. So it offers online discussions, educational opportunities, information for every discipline related to ECMO care. There'll be a great space to share stories, share education, monthly coaching that will kind of come up in an exclusive member portal as well. So really interesting and exciting things coming out of the website. During today's meeting though, we are going to be discussing VV ECMO, daily management and therapy goals, nursing management of the ECMO patient and hemodynamic changes. At the end, we will also have an open forum question where you can write your questions in the comment section and discuss with the presenting guests. Feel free to ask questions in the comment section and comment and let us know where you are from in that section. It's always nice to see the global community around. A little bit about myself. I am Anita. I am a nurse. I've been a nurse for the past 10 years and I'm currently in Abu Dhabi working at the Cleveland Clinic. I met Nicole. I was very fortunate to work with her alongside her and we both started ECMO nursing and really tried to develop some sort of start of a program as well there. It was really lovely. Other than that, it's been a wonderful opportunity to see everyone engaged in this ECMO community as well. And it's really nice to see everyone sharing their experiences, different perspectives, and especially during COVID, it was a really nice time that we were able to bond together as a group and see what was happening globally with all these patients. Before we get on to the first guest, I again would like to remind you guys just to keep your microphones muted so that it's easier for everyone to hear. So other than that, I would like to introduce our first guest. Keith is a native of South Florida. He received his BSN from the University of Central Florida in Orlando and started his career in the Cardiothoracic ICU at Tampa General Hospital. It was there that he started working with the cardiac surgical patients, often requiring mechanical circulatory devices such as LVAD, impeller, balloon pump, and ECMO therapy. Currently, Keith is stationed at the San Antonio Military Medical Center in their medical ICU, the only military hospital to provide ECMO therapy in the Department of Defense. So welcome to the discussion, Keith.
Hi there, good morning everyone. Can you guys hear me?
Yes.
Okay, hi, good morning everyone. Again, my name is Keith Bartolome. I'm calling from San Antonio here in Texas in the United States. Good evening, good afternoon, wherever you may be. And again, the big thing I want to talk about today for my section of this meeting is really kind of the nursing portion and kind of that nursing management of ECMO patients. With that being said, the initial training I got at Tampa General Hospital, that ECMO center was primarily nursing driven mixed in with perfusion. And the current ECMO center where I'm currently at here at the San Antonio Military Medical Center here in San Antonio, Texas is also primarily nursing driven with some assistance and management from the ECMO specialists as well as perfusion. The first topic I did want to go over today for everyone here is really transition from an ICU nurse to a bedside ECMO nurse or just working with ECMO patients. Just because, again, we know critically ill patients are sick, but having a patient on ECMO brings a whole new tier or level of acuity. I guess that's different than what we may see in typical medical ICU or neurosurgical ICU or whatever kind of specialty that patient is normally in. And really the first thing I always encourage people to do when they first start working with ECMO patients, whether you're a smaller facility that's starting to initiate their own ECMO program, or it's been a center that's been doing ECMO for a few years now, is to really to actually take responsibility for your learning and to continually learn outside of work. In that essence, I know most shifts are typically 12 hours, but I really encourage people as they start to work with ECMO patients to really take that initiative to work on your own time outside of work and to learn more about ECMO, focus on your basic assessment skills, and to really review some of the things that you may have learned over the years. Because when you're working with ECMO patients, paying attention to details is very, very important. As we get more experience down the road and you start working with these ECMO patients, it really becomes imperative that you really understand, if you utilize ECMO specialists currently as part of your program, to really understand yourself as ECMO bedside nurse, to really understand how ECMO functions, how it supports the patient, and how it affects the pathophysiology the patient may be going through. So what may be a GI bleed, and a patient may be undergoing a GI bleed in a typical medical ICU setting, it has very different parameters in a different context when the patient is on ECMO. And so you have to really, I guess I compare it to a pregnant patient. It's not just the mother you're worried about, but you're also worried about the baby as well. So it's kind of this duality to it. And so that's how I compare it for patients on ECMO. It's, yes, you're taking care of the patient, but there's also this other major factor involved in their care, which is the ECMO circuit, which can really, can be very lethal if, a mistake happens or if something is overlooked. And the last point I want to make in terms of progressing from as a critical care nurse to a bedside ECMO nurse is really understanding how to communicate with other healthcare professionals. Depending on what kind of background you may have, what kind of facility and resources you may have, it's so imperative that you understand that really ECMO is not just the ECMO specialist and the critical care intensivist who manages the ECMO program, but it is really such a team effort to really get these patients to where they need to go, whether that may be, a transplant route or road to recovery, or whether it may be hospice or palliative care, essentially. It really takes a whole team to get these patients, and it takes a lot of man hours, effort, and resources to really to support these patients on ECMO, whether it be, consulting dietary, vascular surgery, whoever it may be, physical therapy, occupational therapy, and we'll get that into a later point in a few minutes. The second emphasis I want to make during this talk is really the importance of having a thorough patient assessment with patients on ECMO. And this is crucial because, again, really, if you think about the history and context of ECMO, it really is a modified circulatory bypass machine, essentially. And you have a lot of blood circulating outside the body that is, you could essentially lose so much blood due to an incident, if someone's running over the tube or if there's a disconnection. And so when I say assessment, it's not just your typical head to toe assessment, but you're also incorporating that whole ECMO circuit to do your safety checks. With that being said, I wouldn't think of it as a separate assessment, but really as an extension of your basic head to toe. Because remember, at the end of the day, while ECMO may be very exciting and new to some of you individuals, or maybe you are used to it already, there's always a patient at the end of that ECMO circuit connected. And we gotta remember, no matter how many circuits, machines, mechanics, et cetera, are involved with patient care, you gotta remember there's always a person involved with that. And so the way I personally like to do it is my typical head to toe, as I do with every patient, and then I work on the ECMO circuit. So I like to compare it from the patient to the pump is like my key phrase, I guess you could say. So, assessing the patient first and then work my way towards the ECMO circuit. Other major points for those who may or may not be familiar, or maybe you're not in a critical care setting, I always verify all my lines, drains, airways, tubes, the placement, where they're at. I'm also doing neurovascular checks, and depending on your facility's protocols, I'm used to doing it, even though my facility doesn't require, I do it pulses every Q1 hour, a neurostatus, capillary refill. I'm always inspecting the dressings wherever the cannulation sites may be, whether in the IJ, whether in the femoral or subclavian, wherever it may be. I'm always checking to make sure that they're in the proper positioning. And usually depending on the facility, they use a marker or they put some kind of tape or some kind of adhesive to mark where the actual cannula is or where it is in relation to the skin. Besides that, another important aspect when you're doing your assessment with ECMO patients is really ensuring that you have all your safety equipment. And for me, that involves a bag valve mask, having spare trach supplies if they're trached, having spare oxygen tanks somewhere in the room or in the near vicinity at least, or knowing where they're at, having spare supplies, especially like suture removal kits, things like that, and then the spare clamps as well. Because you have to remember these tubing, and God forbid if something happens and there's a disconnection or the patient's accidentally decannulated, you want to either make sure you control that bleeding. And so that's why it's important to have several clamps available nearby. And usually they hang it on the actual ECMO circuit pump on a ring or something like that. And as you're going through this, it's also important to know with anticoagulation, just because these patients are prone to bleeding, it's a kind of a fine balance of trying to anticoagulate the patient, but also making sure that they're not so anticoagulable that they're at risk for major bleedings, intracranial hemorrhage, GI bleeds. So you'll see as you work with ECMO patients, there's this kind of delicate balance that you'll see physicians try to play of we want to make sure they're adequately anticoagulated, that they're not going to thrombose the pump or have all this fibrin buildup on the circuit or on the connections or anywhere on the cannula positioning and the cannula tips. But at the same time, we don't want to expose them to too much risk of having them spontaneously bleed, wherever that may be. And so as you go along, as you get report from the oncoming or offgoing nurse, it's important to understand what are their PTT, what is their anti-10A, ACT, whatever your facility uses in terms of monitoring anticoagulation, whether it's heparin, bivalirudin, argatroban. It's important to understand what you got the parameters are for your facility and what the goals are for anticoagulation. With that being said, it's also important to know things such as type and cross, making sure that's current, having blood products on hold. And that's important because in case, for whatever reason, the patient may be hemolyzing on that pump and their hemoglobin may be dropping, they may not be oxygenating as well. It's important to make sure that you have blood products on hold in case they're hemorrhaging as well. The other point I want to emphasize too when you're doing these patient assessments is knowing their cardiac function and hemodynamics. And if you're not too familiar with hemodynamics, this goes back to my original point, really understanding your basic assessment skills and, doing that self-education and learning outside of work, because you probably won't be exposed to everything on during your shift. So it's really imperative that you learn all these things and know what your deficiencies are. Knowing how, the SVO2 is affected or SVR, all these terms, in terms of that, also knowing the ejection fraction, when was the last TEE done? How is their heart, functioning overall? Is their RV dilated? And all these, at least from the bedside ECMO nurse, you might not need to know the ins and outs necessarily of all these sets, but you need to know the general gist of how these are affected and what kind of information and how that affects, the ECMO specialists or the ECMO intensivists and how it affects their decision making, knowing, that TE, TTE, and knowing their cardiac pressures if they had a left heart cath or a right heart cath recently. The other part on top of that is just the respiratory function, knowing, what kind of vent settings are they on, knowing what kind of sweep they're on in liters per minute, minute ventilation, tidal volumes. And again, especially with this COVID pandemic that we've gone through and all these patients on VV ECMO, it's important to know these patients are here typically for months at a time. These are not patients, VA ECMO patients that may, be there for a few weeks or a month or so. These VV ECMO patients that had COVID-19, they're there for months at a time. And so there's this always, if you look back at their respiratory function, you'll see all these variations. There P+5, there was 8, and it's a lot of trying to find the right settings that accommodate, their physiology on the ventilator. With that being said, blood gases, if you're not familiar with blood gases, I encourage you again to research and educate yourself on that, because that is kind of the standard tool of how we evaluate whether the patient is oxygenating and ventilating well. And now it's not just the ventilator, it's also the ECMO circuit where we can adjust the patient's support for oxygenation and ventilation. So it's kind of a three-way support, the patient's native lung function, the ventilator support, as well as the ECMO support. So you have this kind of interconnected way or system of supporting the patient that you really need to pay attention to. So if someone's adjusting the sweep or adjusting the FiO2 on the ventilator, you need to know how that's going to affect the patient, or learn how to reassess afterward to see if it does have a therapeutic effect. Besides that, the real closing point for this part I want to emphasize is really when you're doing your assessment for ECMO patients is to really keep it in a systematic way. At first, like when I started working with ECMO patients, a few years ago, I had some great mentors back at Tampa General Hospital, and they really taught me the importance of being systematic and being attentive to detail. So however you are, make sure you're doing a very systematic method so that way you're not leaving any stone unturned, however that may be. If you prefer to do pump to patient, where, that is all preferential, as long as you have a systematic method to make sure you do all your safety checks, that that you're really taking care and paying attention to the full picture of the patient, and not just little points and focusing on only key things. With that being said, specifically, the next part I want to get into is really the nursing assessment points on the ECMO circuit. For that, part of it I kind of overlapped with earlier. That's your safety checks. That's having all your clamps available at the bedside in case you need to clamp the tubing if the patient starts exsanguinating, the bag valve mask, spare trach supply, spare equipment for ECMO. Sometimes the perfusionist or ECMO specialist, depending on who's responsible for what functions, they'll have spare supplies for, they'll have a spare primed ECMO circuit pump at the bedside or somewhere on the unit, having the large, like 60 cc syringe in case you need to reconnect the tubing for the ECMO pump, just doing all those safety checks. The other thing, like I said earlier, patient to pump or pump to patient, just keep it systematic. The section I wanted to talk about was cannulation sites, checking where the actual site is for the ECMO cannulas. Again, whether it's in the IJ or whether it's in the groin, in the femoral artery or femoral vein, checking the dressings, make sure they're not bleeding, or if they are, knowing how much they're bleeding, if it's something that warrants, further intervention, knowing where they're aligned, as well as the type of catheter. So whether it's a multi-stage, a maquette, or a single stage, 25 French, whatever it may be, just knowing what kind of cannula size, because that ultimately affects the flow that you can dial in on the ECMO pump. Besides that, when I said the patient to pump or pump to patient, is checking all the connections. It's not just one smooth, long tubing. Sometimes they have to reconnect tubing and they have to usually zip tie to secure it. So checking all and any connections along the pump and along the tubing to make sure they're secured. And sometimes they can be prone to fibrin, and that's just anecdotal experience. You'll see sometimes fibrin, the white strands along those connection points. The next part you should also observe for on the ECMO circuit is the pump. I have not seen this, but I've heard it from a colleague of mine back at my previous facility where she saw a crack in the pump and that warranted a full exchange. Just making sure that there's no obvious defects in the actual material or the product itself from the ECMO circuit. So that there's no cracks in the pump, that you don't see any obvious clots or fibrin. And then moving on from there is moving on to the oxygenator. I'm used to seeing Sorin and as well as the CardioHelp. The CardioHelp, you can only see one side really of the oxygenator. But with Sorin, you can see both sides of pre-oxygenator and post-oxygenator. And really what you want to look for is the fibrin and clots. And depending on the anticoagulation of the patient, you just want to see, are they building up clots really quickly, or are you just seeing slow fibrin depositing onto the sides or in the middle of the oxygenator? And if it's on the pre-oxygenator side, some folks tend to be okay with it. It's really where people on the post-oxygenator side, people tend to get a little more concerned because that's going directly back to the patient circulation. So really assessing, and again, this is something I'm used to checking every hour, just seeing the progression, if any. The best case is there's no fibrin, no clots, but sometimes, you'll see it progressively get worse and what looks like almost like curdled dark cheese almost, or moldy cheese. So really assessing and letting the providers know, like, hey, this oxygenator is starting to clot off completely, or it looks like it's getting worse in a short amount of time. That's something to be concerned for. And really you want to assess how's that oxygenator functioning. Because if you think about its job is to literally oxygenate the blood and remove carbon dioxide. So you want to make sure you're checking pre and post gases, whether it's you, the ECMO specialist, perfusionist, whoever it may be, you should still be aware of what the ABGs or VBGs are from the pre and post gases. And that way you can assess and be aware, how is it functioning? Is the PO2, significantly lower than it should be on the post-oxygenator? And again, you expect the oxygen levels to be much lower than the post-oxygenator, but you want to assess how is that individual part of the ECMO circuit functioning, because there are times where you do need to exchange the oxygenator if it's clotted off too much, or if the pressure, if you read the pre or post pressures, you can tell by the delta P how well, if there's too much clots building up, and that could warrant an exchange, or if the patient's simply not, if they're hypoxic or hypoxemic. The fourth point I want to make for this, you guys, is really, again, no matter where you are in the world, however if it's government run, private run, whatever kind of facility you're at, is really to learn how to work with others. Unfortunately, there is a high mortality rate still involved with ECMO. And so it's really, there's multiple people involved in the care. That's besides the ECMO bedside nurse, the intensivist, ECMO specialist. And it's really having, physical therapy, occupational therapy involved as early as possible if they're working on a road to transplant. Sometimes if they're able to get decannulated, getting psychiatry and psychology involved, because this is a very stressful event for patients. I have a family member that I know that was on ECMO, and when you can't breathe, that's just very anxiety inducing. And you really want to make sure that they're able to get their good sleep hygiene, especially being in ICU, managing the stress, any depression they may have. And of course, that's not our most forefront concerns, especially when they're in such a critically ill state, but that is something they do experience oftentimes, especially when they're there in the ICU for potentially months. And really also getting the patient and the family involved, because what do they want ultimately? The patients, if they're learn oriented, they can change their mind if they're fully sound and neurologically intact. Maybe at some point they may decide they don't want to be worked up for a transplant anymore, or maybe they just don't want to deal with the whole ECMO process and deal with that. And ultimately you got to remember that, again, there is a person at the end of the pump, and if they are able and sound mind, we still have to respect their wishes. As much as great of a therapy and so much resources we may have to support them, we have to ultimately and should respect their wishes at the end of the day. And the last point, folks, I just want to mention, especially for the nurses here, that you may see, especially when you're at the pump, for your 12-hour shifts, and it's kind of sometimes hard to convey words or try to convey the idea of like something's wrong with the patient, or you don't know how to quite put your words on it. Some of the complications I want to go over are next. So this one primarily is bleeding. Like I mentioned earlier, they're usually on anticoagulation, bivalirudin, heparin, et cetera, whatever your choice of anticoagulation may be at your facility. And for some, anecdotally, I just remember seeing a lot of nasopharyngeal bleeding, and it always involved an ENT consult, because they would just start spontaneously bleeding either from the oral cavity somewhere in the nasopharynx. And it would just be a whole concern and workup for, are they, do they have a GI bleed? Do they have something else going on? Are they having intracranial bleed? And thankfully it wasn't, most of the time I found out it was just, they had spontaneous nosebleed essentially. But there are some times where their patient does have an intracranial hemorrhage or some other kind of bleeding from their wounds, or especially their cannulation site, or maybe from one of their access sites from like their cordis or their, intrajugular lines. Other big things to look out for is thrombosis, again, pump at the connections. Another one's limb ischemia. And again, this is part of one of my checks when I'm checking the patients, the neurovascular checks, checking them, making sure their extremities are warm, cool, whatever it is their baseline may be, checking for pulses, checking if they have any, numbness or tingling, if they're able to respond. Because sometimes, especially with VA ECMO, more specifically, you'll see a lot of times when they place that cannula, it occludes the artery, and you'll see a lot of very pale, like very white, snow pale limbs or extremities. And it always involves usually a vascular consult to really assess the flow to the extremities to see if it's adequate, God forbid, amputation or any other surgical intervention. But those are big things to look out for, is limb ischemia. Other things to look out for, hypercapnia, hypoxemia. Again, that's just assessing your blood gases, make sure the patient's getting adequate oxygenation, that they have good organ function, that they're voiding, things like that. Last two things I want to talk about, low flows. You may hear the term chugging in some places. They know it as chattering. and just really making sure that the patient has enough volume. And that's where you'll see, again, the circuit, it will start vibrating. Essentially, sometimes the RPMs are too high and the flows are too high, or there's not enough volume. And whatever the source may be, just really assessing why is this, why is the ECMO circuit chattering or chugging, essentially. And oftentimes, sometimes a little bit of albumin will help, or sometimes simply decreasing the RPMs, assist with that issue. And that ties back into knowing your ECMO cannula size, so that way you know what kind of flows can be tolerated on that kind of cannula that's currently inserting the patient. And the last one, again, is pressure injuries and infection, especially if they're there for a long time, just making sure they're turned, repositioned, that, that patient is turned appropriately and that they don't get any pressure sores or anything like that.